Silicosis, a CRRS 121 project, produced by Islaine and Susanna. What is silicosis? Silicosis is a disease common in construction workers, underground miners, sandblasters, and many other occupations in which a person is at risk of inhaling silica. Silica is a common component of soil and rocks, and when these fine particles are inhaled, people can get inflammation, where the lungs fill with fluid, or fibrogenosis, where the lungs stiffen. Inhaled silica dust can lead to 3 different types of silicosis. Simple or chronic silicosis and accelerated silicosis are 2 types, both of which result from exposure to low levels of silica for a specific duration of time. Simple or chronic silicosis is for 10 or more years. Accelerated silicosis is for 5 to 10 years. The third type of silicosis, acute silicosis, is the most deadly type. It can develop from high levels of exposure for a short period of time. In addition to silicosis, silica dust can lead to increased risk of infection, such as tuberculosis, autoimmune diseases such as rheumatoid arthritis or scleroderma, non-malignant kidney diseases, or lung cancer. Furthermore, silica dust has been associated with other cancers including esophageal, stomach, skin, and bone.
When silica particles are inhaled, they can be deposited into either the upper respiratory airway or the lower respiratory airway, depending on their size. If they land on the upper airways, our body's own mucociliary escalator can remove them right away, in the form of coughing, sneezing, or swallowing. However, it is the silica particles that get into the smaller airways that cause the problems. Once the silica particles are deposited into the smaller airways, what happens is that alveolar macrophages are attracted to the site. What they do is that they engulf the silica particles, but at the same time release a cytokine called interleukin 1. This interleukin 1 plays a central role in regulating the immune and inflammatory response. What they do is that they stimulate and recruit and proliferate T lymphocytes. And once the T lymphocytes are activated, they secrete a variety of chemical mediators, such as chemotactic, tumor necrosis factor, and even more cytokines. What's important here is that these chemical factors, they start the cell-mediated inflammatory cascade. At the same time, these alveolar macrophages also stimulate neutrophils to come in. These neutrophils that came in release proteolytic enzymes and generate reactive oxygen species, which start to cause epithelial damage and extracellular connective tissue degradation. So while all this is going on, the body also tries to repair the damage. So the macrophages also release growth factors, platelets, that recruit type 2 pneumocytes and fibroblasts, which in turn produce large amounts of fibronectin and collagen. And these fibronectin and collagen are the reason how scar tissue is starting to form. One of the clinical signs that patients have silicosis is through pulmonary function testing. These pulmonary function testing may appear normal in the early stages of silicosis, but as the disease progresses, patients are found to have decreased total lung capacity, vital capacity, and decreased volume of exhaled air over 1 second. And this is because as fibrotic tissues build, lung loses its elasticity, so the compliance is decreased. So it becomes increasingly hard for the lungs to fill with air. Therefore, consequently, their pulmonary function testing results resemble those characteristic of restrictive pulmonary diseases. Another clinical manifestation of this disease is exercise-induced hypoxemia. Normally at rest, patients with silicosis, their oxygen saturation is adequate because with normal cardiac output, oxygen has enough time to cross the alveolar capillary membrane to saturate the blood. However, as scar tissues and obstructions starting to form within the airways, the oxygen partial pressure gradient is greatly decreased, and the alveolar capillary membrane thickness is increased. And according to Fick's law of diffusion, if we decrease the oxygen partial pressure gradient and increase the membrane thickness, consequently the oxygen diffusion rate is decreased. Bearing that in mind, when our patients with silicosis start to exercise, their cardiac output is increased, and with their decreased oxygen diffusion rate, their oxygen does not have enough transit time to saturate the blood, and this is why they become hypoxemic. Patients with silicosis also may experience shortness of breath and severe coughs. Auscultation of the lungs often reveal decreased breath sound in the upper lobes of the lungs and the presence of bronchi crackles. Because most of the silica particles get deposited into the upper areas of the lung, ventilation to those areas are compromised, creating shunt. Therefore, little breath sound is heard. And due to the chronic inflammation and scar tissue buildup, patients' work of breathing is increased. And they try to reduce their work of breathing by taking smaller breaths and breathe more frequently. Other clinical manifestations of silicosis include fatigue, tachypnea, loss of appetite, weight loss, chest pain, fever, and cyanosis.
To diagnose silicosis, a patient's medical history is needed to determine periods of exposure to silica dust and to write off other potential illnesses which could cause the same symptoms. This could include asking patients' current job, past jobs, hobbies, and/or other activities exposing them to silica dust. A chest X-ray showing nodules along with patient history confirms silicosis. This is usually visualized by nodules found in upper zones or more lower zones in severe cases. Knowing patient history, pulmonary function testing can confirm the onset of silicosis and monitor changes in airflow patterns in and out of patient lungs as the disease progresses. Lastly, invasive procedures like lung biopsy can confirm silicosis and exclude other potential diseases, although these are seldom needed. There is no cure for silicosis. Treatments and medications are meant to provide relief of symptoms to patients. These include corticosteroids, bronchodilators, cough suppressants, and mucolytics. As silicosis becomes more severe, patients may require antibiotics to fight off the increased risk of infections, and also oxygen in cases where patients' lungs now have impaired ventilation or oxygen absorption. Although rarely seen, more invasive procedures can also be used, as they have shown some improvements to patients' lung function. Whole lung lavage can relieve some symptoms by removing large quantities of dust, cells, and soluble materials. However, this has not had long-term benefits. Lung transplants may also be used in severe cases, especially for young patients. Silicosis is chronic and cannot be cured. Depending on the type and severity of silicosis, people afflicted may live for many years or only a few months. Once the lungs have been affected, there is no way to reverse the damage. In general, the goal of medical interventions is to minimize the symptoms and slow the progression of silicosis. To slow the progression, people with silicosis may be advised to avoid further exposure to silica dust. However, if working in optimal conditions, the inhalation of silica can be minimized in spite of its presence. Understanding what causes silica dust and how to avoid it are essential components in both preventing silicosis and slowing its progression. It is important to know the source of silica dust. Water sprays may be used at the source to wet dust particles before it becomes airborne to avoid inhalation. Using fitted masks and respirators designed specifically for silica dust particles can minimize inhalation of dust. Employers can create an ideal work environment by utilizing water sprays and enforcing the use of respiratory equipment. However, it is essential that a person understands what causes silica dust and how to avoid inhaling it to minimize the risk of silicosis.